finish because that's all we have time for. So with your EKGs, the biggest thing, just like with anything, you know, when you get a patient's vital signs and you get something really crazy, you don't just treat the vital signs, right? You treat the patient, you make sure it's accurate, you recheck it. If it's, you know, really high blood pressure or really low blood pressure, you treat the patient. Same with your EKG. You always want to treat the patient. If the monitor is alarming V-Tach, and you go in and check on your patient, you know, you're gonna, if they're talking to you and perfectly fine, you might want to double check their leads and make sure their leads are accurate. Or if it's saying asystole and they're talking to you, well, you definitely know it's not accurate. So always treat the patient. If it is accurate, then you're gonna assess your patient as to whether they're stable or unstable. Are they starting to have symptoms as a result of this dysrhythmia? Are they tachycardic with hypotension? Are they becoming diaphoretic, loss of consciousness, those type of things? So you always want to assess your patient and treat the patient, not just the monitor. And lots of things can lead to dysrhythmia. As we know, drugs obviously are a big thing, but even things, non-illicit drugs, you know, the normal drugs that they're on that could cause, you know, beta blockers can cause bradycardia, or caffeine can cause tachycardia, electrolyte disturbances, just disease processes, and age. Age can also increase risk of dysrhythmias as well. But hypoxia is a really big thing. You know, if a patient doesn't have adequate oxygenation, we know that the heart needs oxygen to pump to the rest of the body. It needs that oxygen to perfuse well and to have a normal rhythm. So a lot of disease states that just cause hypoxia can cause our dysrhythmias. So here we have the electrical system of the heart. So it's really important to know where the different areas come from, so that way you know what type of rhythm to expect if you know that area of the heart is having some damage. Especially when we start talking about MI next week. So it'll depend on what part of the heart that the MI occurred as to what type of dysrhythmia you are going to want to be looking for. So first we have our SA node. So there's these three main areas: the SA node, AV node, and the bundle of His. All these nodes have a property of automaticity. Automaticity meaning that it can originate an impulse on its own. So that's why when you have a brain death patient, that the heart still beats, because it has that capability of automaticity. It can still beat and perfuse without brain function for a time, but you know, eventually all things must cease without the brain, but it can. So the SA node, as you can see there, is located right here, what is right here? What is this chamber of the heart?
Right atrium.
Right atrium.
Right atrium, yeah. So that's our right atrium. The SA node sits in the right atrium. Then our AV node, so then those impulses go through the SA node, go to the AV node, and then down through the bundle of His, which then goes to our ventricles. So the SA node has a rate of 60 to 100, which is our normal heart rate, right? Our normal heart rate is 60 to 100. So our SA node is the main pacemaker of our heart. If your SA node starts to have problems or something happens that knocks out that SA node, then it can default to our AV node, but that rate is slower. It's a rate of 40 to 60. Then if the AV node happens to malfunction, you know, if it's a big, you know, right MI and knocks out both those nodes, then the bundle of His is what is going to kick in. And that is at a very slow rate of 20 to 40. So they can, you know, originate those impulses if they have to, but the SA node is going to be your primary pacemaker to control our heart rate. So with the AV node, so your impulses go through your SA node down to your AV node. Your AV node then allows for the last little bit of atrial kick. It allows for the last little bit of blood to pump out of the right atrium and go into the ventricles, and just gives that last little bit of cardiac output. with that atrial kick, it accounts for about 20 to 40% of our cardiac output. So it's important to have that atrial kick to have the best optimal cardiac output possible. And then with your bundle of His, as you can see, your bundle of His goes down your to your ventricles. It can go to the right ventricle, and then it goes to the left ventricle. So these then that kind of branch off are your bundle branches, or your Purkinje fibers off your bundle branch. So your if you've ever heard that a patient was diagnosed with like a right bundle branch block or left bundle branch block, that is where it's occurring. There's a block somewhere in that electrical system of the heart that is slowed. So it has a slowed response. And the way that you can tell if it's a left or a right, just by looking at an EKG, is the deflection of the QRS. The QRS is the main, EKG complex that indicates our ventricular depolarization or our ventricular contraction. So if that QRS is widened, because normally it should be narrow, it should be less than 0.10. If that is widened, then they have a bundle branch block. So there's a slowing in that area of the conduction. So when they have that block, if it's an upward deflection, so think of it like a turn signal. So when you go to turn right, you push your turn signal up, right? So if it's going up, it's a right bundle branch block. If that complex is flipped and pointing downward, well, we push our turn signal down to turn left. So that's an easy way to remember. If you see a really wide QRS and it's pointing downward, then you know that they have a left bundle branch block. So then when you go, here's a better picture of it. So here, every section will show up on your EKG in a certain segment. So your SA node is represented by your P wave. Your P wave is your atrial depolarization or your atrial contraction. Your SA node is located in the right atrium. So it goes hand in hand. So when you see a P wave, you think atria, you think SA node. Then your PR interval is represented by your AV node. So that is the length of time it takes for that electrical impulse to go from your SA node to your AV node. So there is your PR interval, and that normal rate is should be less than 0.20. Then you have your QRS. Your QRS is your complex that signifies your ventricular depolarization or your ventricular contraction, and that is your bundle of His. And then your ST segment, which your QRS should be less than 0.10. I didn't say that yet, right? Then you have your ST segment, which represents early ventricular repolarization. So it's the start of the filling of your ventricles. Then your T wave is the resting state of your heart. That is your ventricular repolarization. So that is your heart at rest. And that is the most vulnerable time of the heart. So if anything were to happen, like they get shocked or something, and it happens during that period, it can be it can essentially either knock out the rhythm altogether or cause them to go into VTAC. So when we talk in a little bit here about cardioversion and defibrillation, it's very, very important that the patient does not get shocked on the T wave, because that will just completely knock out their rhythm or cause a severe dysrhythmia. So that's the resting state, and we don't want to disturb it. So then you have a U wave there, which U waves are usually benign. Some people just have them for no known reason, but it can signify like hypokalemia potentially, or heart disease. But in a lot of people, it can just be benign. So the biggest thing to remember as we move forward talking about the different types of dysrhythmias is that anytime you see a problem with the P wave, you know there's a problem with the atria. So it's an atrial something, atrial fibrillation, or it might just be a sinus tachycardia. If you see, P wave will always indicate like a sinus rhythm, and if there's a problem with it, it's an atrial problem. And then the QRS will always represent your ventricles, and if there's a problem with that, then it's a ventricular problem. So always remember that. P, atria, QRS ventricles. Okay, so then you have your the way we monitor. Most, we do have our 12-lead EKG, what we'll talk more about with our MI next week. Your 5-lead monitoring then is our common telemonitoring. If you're in the, like on a tele floor or any floor with a, with EKG monitoring capabilities, you need to know how to place your EKG leads. So one way, most of them have the letters on them, so it's kind of a dead giveaway. RA, right arm, LA, left arm, not on their arm, but close to that area. And then LL would be left lower, RL, right lower, and then the V lead always goes in the middle. But if you happen to have one that does not have the letters on it, an easy way to remember is because they'll always at least have colors. If they don't have the letters, they're going to have the colors on them. And that's standard. So one way to remember is that white always goes on right. And then you have sky over grass, smoke over fire, and chocolates close to the heart, or whatever you want to think for your brown lead. But the brown lead always goes in the middle. So that's one easy way to remember that in case you don't have one that has the letters on them. So the effects of your of your electrolyte disturbances. Oh, and I forgot to mention, whenever you're placing your leads, one big thing that can cause a lot of ectopy is hair. So if a patient is real hairy, hopefully it's a man, you might need to shave them first before placing the leads, because sometimes if you place it over hair, it is just not going to pick up, and it's just going to look like a bunch of like artifact, and it doesn't read accurately. So you really want to make sure that you're prepping the skin adequately before you put those patches on and that they're staying on. Or sometimes if they're real sweaty and diaphoretic, you might need to just make sure they're dried off first too before you place those leads. Okay, so effects of electrolyte disturbances. The 3 most important electrolytes for the heart are potassium, calcium, and magnesium. Phosphorus can affect it as well, but not as much on the actual electrical disturbances for the heart. So potassium influences both skeletal and cardiac muscle. If you have hypokalemia, you'll see a more flattened T wave. You could potentially see the U wave. And then with hyperkalemia, you'll see a more tented, like a peaked T wave. And then in both cases, if they're severe enough, they can go into VTach. And that VTach is one of the hardest codes to kind of get a patient out of until you either replace the potassium or remove the potassium. Sometimes you might need emergent dialysis or something. But especially like with hypokalemia, I had a patient a few months ago that just kept going into VTach like constantly, and we kept having to code him and shock him to get him out of the rhythm. But he was only out of the rhythm for like 10 minutes before he went right back into it. So we were trying to give that potassium as fast as we could without being harmful, to try and bring his potassium levels back up, because it's just, if it's severe enough, and his was like 1.9 or something, it was crazy low. So if it's low enough, they're going to keep going back into VTach until it's replaced.
Did you say hyperkalemia was peaked T waves?
Hyper is peaked, hypo is flattened. Yeah. And what was I saying? Oh, calcium. Calcium then transmits your nerve impulses and helps regulate the muscle contraction and relaxation. Your calcium, if it's low, it can cause a prolonged QT interval. So your QT is the start of depolarization to the end of repolarization. So that QT interval then can be prolonged with low calcium levels. Can also shorten or shorten the ST segment, prolong the PR interval, and can potentially cause heart blocks and asystole if it's severe enough. Low calcium can also enhance the effects of toxicity. Oh, I'm sorry, that was high. Low causes the prolonged QT, high causes the prolonged PR interval, the heart blocks and asystole, and potentially worsens the effects of DIDGE toxicity. Then we have magnesium, affects the neuromuscular irritability and contractility, acts peripherally to produce vasodilation and decrease peripheral resistance. So with your magnesium, low can cause prolonged QT intervals as well. It can also cause a decreased ST segment. And we know our ST segment is what we look at when we're looking at MIs. When you have that ST elevated MI, it's that ST segment that is high. You know, you get that. It's not isoelectric, which I forgot to mention. Let me go back to my RIT wave. So your ST segment here should always be isoelectric. So meaning it should always be equal to like your PR line as well. So this should always be equal. If it's not, then that can indicate some issue. So the biggest one we know is with that ST elevation. So if it starts like way up here and then goes down to your T wave, that is what we look for when we're looking at MI. So if they have a ST elevation, then there's some type of injury or something going on. So that's why those patients go to the cath lab right away. You know, if they're having a STEMI, ST elevated MI, that's what a STEMI is that ST elevation. Again, we're going to talk more about that next week. All right. So then with high magnesium, you're going to have a prolonged PR, a tall T wave, and a widened QRS. And it can also cause those blocks as well, those heart blocks. And Torsades VTach is one that's often caused by magnesium. And what you see, it's really hard to identify. Sometimes, you know, physicians say that it's torsades, and it's really hard to tell, but it's basically almost looked like a twisting of that QRS complex that's in VTach. It just looks different. I don't even really know how to describe it. And sometimes it's really hard to even judge anyway, just with ectopy and stuff that's going on. But sometimes if they are experiencing that, then they might give like magnesium or something during a code to help with torsades. All right, so you have your electrical recording paper, the paper or the monitor. Doesn't really print out anymore like it used to. You just print sheets of it now. But it does move across the monitor at 25 millimeters per second. It just always runs at that constant rate. So in order to determine heart rate, we need to know how our those little squares, what the measurement are. So this small little square, which I'm going to zoom in here. All right, so one of these small little squares right there is 0.04 seconds. And then one big block is 0.20 seconds. So it's important to know that because then it makes it easier to measure our complexes. So you can measure your PR interval, you can measure your QRS intervals, and anytime that PR interval is greater than 0.20, we have a first degree block. So it's really easy if you just measure up your PR, which is the beginning of your P wave, which again right here, your P to your R, so the end of that right before it dips down to go to the QRS. That's our PR interval. If it's longer than that, then they have a first degree block. If it's longer than that 0.20 or bigger than one of those big blocks, it's considered a first degree block. So then 5 big squares then, so 5 of those big blocks equals 1 second, 15 of them equals 3 seconds, but what we normally go by is 30. That gives us 6 seconds. So then if we count how many complexes we have in a 6-second strip, we just multiply it by 10 and that gives us our heart rate. So it's a really easy way to determine our heart rate. So let me go to an actual strip here. So here we have sinus rhythm. And what you will see on paper or rhythm strip, whatever you're looking at, is you'll see these little tick marks up here. There's one right here too, and then one right here. But usually the 2 bigger ones signify 6 seconds. So then one here in the middle, that would be your 3 second. So you always want to have a 6-second strip to determine your heart rate. Then you just count your QRS complexes in between each one of those little tick marks. So looking at this rhythm strip, what's our heart rate?
Is it 80?
Mm-hmm. Yes, it's 80, not 90, because this one right here is just outside that mark. So you don't want to count that one. So one other slightly more precise method is the big block method. So the big block method is pretty simple too. All we have to do is count the number of big blocks between each QRS, between a QRS segment. So you're going to take two QRSs and then count how many big blocks are between them and divide from 300. So how many big blocks between, we'll pick these two. And again, this is something, the big block method you can only use for a regular rhythm, because if this were a fib that's really irregular, you're not going to have a consistent QRS. So you can only do it with a rhythm that's regular. So if you look at this one, so we'll just pick this one. And it doesn't matter which one you pick because it'll be the same as long as it's a regular rhythm. So how many big blocks do we have between these two? Yeah, 3 and like a half, right? Because it kind of goes in the middle of this one. So we have 3 and a half. So then all you do is divide 300 divided by 3 and a half. What does that give us? 85, almost 86. So it's slightly more accurate than your just counting, but if you want a real quick estimate, the easiest thing to do is just count. So your big block method is what could potentially, be a math question that you might need to know, but it's simple math. You just got to know how many big blocks are between a QRS segment and divide it from 300. So pretty simple. Okay, so then there is a third method, but it's like memorizing a sequence pattern, so I don't even go over that one, so don't even worry about it. So the main thing you're going to want to know is just counting your QRSs between a 6-second strip, which, by the way, for testing purposes, if you can't see the tick marks, because it might be the picture just kind of cut off right at the tick marks, just assume it's a 6-second strip. So when you're analyzing your rhythms, just look for the tick marks. If you don't see them, just assume it's a 6-second strip. Okay, so we have the 6 steps to EKG interpretation: the regularity, calculating the heart rate, the P wave, the PR interval, the QRS, the ST segment, and then we determine what our rhythm is. So we got to look at all those things to determine what our rhythm is. So looking at your P wave, is there a P wave there? Is it consistently there? Looking at the PR interval to determine if we have a heart block or not. Looking at the QRS to determine if it's widened, if there's a problem with the ventricular conduction. Looking at the ST segment, seeing if it's isoelectric, if it's high, can indicate injury. It could be electrolyte disturbances, if any of these things are off. And then that gives us our rhythm. All right, so our normal sinus rhythm, we're already on this, but our normal sinus rhythm is just that. It's normal. It's like, everything is exactly as it should be. Your heart rate is between 60 to 100. Your P wave is there and it's consistent with every QRS. Your PR interval is not prolonged. Your QRS is narrow. It's not greater than that 0.10. It's just our normal sinus rhythm. That's what we want, right? Then we have sinus tachycardia. So it's still sinus rhythm. Everything's normal about it except for the rate. So what's our rate in this one?
$120.
Yeah, 120.
Yep, 120. So everything else is normal except it's a rate of 120. So it's over 100, so it's tachycardia, sinus tachycardia. Sinus tach can be normal for some people. Some people might just be slightly more tachycardic. We know other things that can cause tachycardia, just exercise, caffeine. You guys were all probably tachycardic this morning with caffeine and stress at 9 o'clock this morning. So certain things can cause tachycardia, but we always just want to, again, assess the patient. So maybe the patient hasn't been tachycardic, they were in the 70s, and now all of a sudden they are this rate, a rate of 120. You go check on them, and maybe they're working with physical therapy, or they're up in the bathroom, you know, but still benign, but just can be results of something that we don't necessarily need to treat. We would only need to treat the cause if necessary. So if they become very tachycardic with like shortness of breath, something like that, then we might need to treat it. You know, just to have them rest would be the first thing. But removing any of those things that could potentially worsen tachycardia. So, you know, if they're drinking a lot of caffeine, nicotine, you know, if they're on a medication like dopamine or something that's causing contractility, increased contractility, you might need to go down on the dopamine, something like that. Then we have sinus bradycardia. So our sinus bradycardia, again.
Tachycardia. Yeah. So like when you're looking at that strip, the QRS, like the S dips down farther than the regular sinus rhythm. Mm-hmm. Why is that?
That's normal. I mean, honestly, a QRS often does. And the other one, let me go back to the other one. Yeah, I mean, this one just doesn't happen to, but it's not abnormal to go to dip down further like that.
Okay.
Yeah. I don't have an actual good reason as to why some do and some don't, but it's normal. It's the widening of it is that you want to look at the most as far as when it comes to the QRS. That isoelectric line doesn't really pertain to the QRS itself, just the ST segment is the main thing. But some are even, some are go down. And sometimes it depends on the placement. The lead placements too can kind of cause a little bit differentiation between the way that sometimes a rhythm looks a certain way. So, but yeah, it doesn't signify anything. Okay, so then we have sinus bradycardia. Sinus bradycardia is your sinus rhythm, but bradycardic. So this one is a rate of 40. So it's less than 60, so we know it's bradycardia. But everything else is normal. Your P is normal, your PR interval, your QRS, your T wave, everything else is, your ST, everything's good. So again, this could be normal for some people. We know athletes tend to have a lower heart rate, runners especially, because their heart is more efficient. That's why athletes tend to have a slower heart rate, because they achieve the cardiac output that their body needs at a slower heart rate, because they just have more, their heart's just more efficient. I don't know how else to describe it. So they don't need a higher heart rate in order to obtain that cardiac output. So you would only need to treat your bradycardia if it's symptomatic. Some people, it might be when they're sleeping, they go bradycardic. But you know, if they do start to become bradycardic and they're symptomatic, so they're short of breath, diaphoretic, hypotensive, or hypertensive, trying to combat it, you know, that would be the only time that you would truly need to treat your bradycardia, is if the patient becomes symptomatic, dizzy, signs that they have decreased cardiac output, that their body is not perfusing the way it needs to be because their heart rate's too low. So in order to treat bradycardia, then you might need to give the patient some oxygen. Atropine is the main drug that we give to help increase heart rate for sinus or for bradycardia. Dopamine, again, is one that can help raise the heart rate. And then if it's a result, sometimes patients after open heart surgery, there's problems in the conduction pathways afterwards, and they might wind up needing a pacemaker in order to obtain an adequate heart rate. So just, again, you just only would potentially need to treat it if there's a problem. Or maybe it's a med problem. Maybe they're on too high of a dose of their beta blocker. So dosages might just need to be adjusted, those type of things. All right, so here we have AFib. Atrial fibrillation. So it is really looks like the name implies. atria is our P wave, right? If our P wave will be affected if it's an atrial problem. Do you see any normal P waves here? There's no normal P waves. So it's an atrial problem because you can't identify any specific P wave. And what that atria is doing is it's fibrillating. It's just like quivering. That atria just is not pumping the way that it needs to be as it would in a normal sinus rhythm. So it's just quivering. What's happening here is there is multiple foci coming coming and causing that atrial depolarization at a rate of 400 to 600 beats a minute. So it's just like going crazy. It's just quivering, and all these beats are trying to go through at a rate of 400 to 600 a minute because it's just coming from multiple different foci. So what we have then is the AV node will block some of those impulses. So that way they're not, all those 400 to 600 impulses are not going to the ventricles. So luckily, our rate is never at a 400 to 600 because the AV node helps block some of that. But some of them do come through. So you do still, oftentimes atrial fibrillation does often have a rapid ventricular response, or RVR. So you might hear it called AFib with RVR. That's what that is, a rapid ventricular response. So that's meaning that enough of those impulses are getting through to the ventricles, causing a rapid heart rate. But it's not regular, so only some are, just randomly some are coming through. So it's never going to be a regular rhythm. It's always going to be irregular with atrial fibrillation. So since those atrial just kind of quiver and they don't contract, what is it that our AFib patients are at high risk for?
Blood clots.
Stroke.
Yeah, blood clots, especially that go where and cause what?
Stroke.
Yeah, stroke. So an easy way to remember your clots and the problem that they cause, you've got clots in the heart, they go to the head. You got clots in the lungs, or the legs, they go to the lungs. So DVTs often cause PEs, and AFib often causes stroke. So leg, lungs, heart, head. So yeah, they're at a really high risk for stroke because the atria are just quivering, they're not pumping, so that blood is just pooling in the atria and starting to form blood clots. And then every once in a while, it might contract enough that it throws one of those clots out. So that's why they're at a really high risk for stroke. So because of that, they often, that you need to know when their onset of symptoms basically were. So you need to know if it's a new onset AFib or old onset, because whether or not it's new or old determines the treatment that you're going to do. If it's a new onset, if they come into the ER with shortness of breath and palpitations, and you ask them, okay, well, when did this start? Well, I woke up this morning and I just started, just couldn't breathe very well, and I just feel my heart racing, and this has never happened to me before. Well, that should cue you in that it's a new onset. It's a new onset. It just occurred. Now, if they tell you then that this has been going on for a few weeks now, but today it's worse, like it's happened off and on for the last few weeks, but it's worse today. Well, that would be an old onset. The main time frame is 48 hours. So less than 48 hours, we can cardiovert. Greater than 48 hours, they're going to need a blood thinner first, because if they've been in it longer than 48 hours, they're at a much higher risk for stroke. So as you can imagine, if you have a patient who's been in AFib for a while and they're not on any blood thinners, as soon as you get them out of AFib and into sinus rhythm, what's going to happen? Now they've got a heart that's beating really good. They're just
Going to dump all those clots.
Yeah, they're going to start, oh good, the atria is pumping now. And now all those clots that have been sitting in the atria are getting thrown. And that's when we have like shower emboli that occur with those like massive shower strokes. So we don't want that to happen. So it's important to know when their onset was. So cardioversion is a shock. You're shocking the heart back into a normal rhythm. But cardioversion is very specific to the time when you shock. It gets you're not just gonna like shock the patient wherever, because as I mentioned earlier, we never want to shock on the T wave. Well, you can't see the T wave really in AFib. So where you need to shock is on the QRS. So what happens is you hook the patient up to the defibrillator. It's still the same machine, and you synchronize it, and you make sure that when you charge, which you usually don't need to use as much energy for cardioversion, you charge it maybe to usually about 100 joules, and you sync it. So when you sync it, that machine puts little tick marks, like a little arrow above every single QRS. So that way you're telling the machine that is where you need to shock the patient and nowhere else. So then when you hit shock, it won't deliver immediately when you push shock. It'll only deliver as soon as it reaches one of those arrows. So it'll only shock them on the QRS, so you don't risk accidentally shocking on the T wave. So we're going to do a cardioversion for a patient if they are less than that 48-hour marker, and usually more so if they're hemodynamically unstable. So if they are severe, if they're in RVR and they're having hypotension, we need to get them out of that quick if they're unstable. So otherwise, we might try and convert with medications. But greater than 48 hours, they're usually going to get started on regardless, they're probably going to get started on a heparin drip, but definitely those that have been in it greater than 48 hours, we don't want to cardiovert or do anything like that without them being on blood thinners. But medications, our diltiazem is our real common medication that we often get started for AFib patients, or it's a calcium channel blocker, but beta blockers are potential in antiarrhythmics as well. Amiodarone is sometimes the common medication that we give as well, but usually most patients, physicians are going to start with diltiazem. It's usually the most common one that we give for AFib. Can be given IV push and start an IV drip. Same with amiodarone. They'll get like an IV bolus and then start the drip. But what's really important with those medications is you want to just be careful if they have a peripheral IV, because especially amiodarone, patients can lose limbs if it infiltrates, because it can cause severe tissue necrosis if it infiltrates. So if at all possible, if they're going to be on it for a period of time, they usually like to have them with a PICC line or a central line of some sort to prevent that infiltration from occurring. There's also ablation. Ablation is another possible treatment for atrial fibrillation. Ablation is when they go in through a cardiac cath and essentially like burn the area that is causing problems. So they often don't just go straight to that though. That might be, a patient who's had multiple failed cardioversions and medication is refractory and it's just not helping, and they keep going back into AFib. So ablation is an option for those that they just can't seem to correct it with other ways. Trying to think what else. Yeah, I think that was the main thing with that. So again, greater than 48 hours, blood thinners. Less than 48 hours, then you can cardiovert if they're unstable. And otherwise, we're going to treat with our medications to help control the ventricular response and potentially convert them with medications as well. All right, atrial flutter. I'm going to treat it the same way as AFib. The only difference with AFib is that it's coming from one foci. So with atrial fibrillation, it's coming from multiple foci at a rate of 400 to 600. Atrial flutter, it's coming from one foci, usually at a slower rate of like 200 to 300. But since it's coming from one foci, it has you can see multiple P waves. You can see the P waves, and it's usually regular. So, and it might be called like a atrial flutter, a 3-to-1 atrial flutter. So there's 3 P waves to every QRS. So again, you're going to treat it the same way as atrial fib. And it tends to be slightly slower as well, just because it is just the one foci, but not necessarily. Sometimes it still can have that rapid ventricular response as well, but you're going to treat it the same way as AFib. Then we have, flutter, a flutter and AFib are often really common with valve disease, which we'll talk about valves and stuff next week as well, but they are more common with valve problems. All right, then we have SVT. SVTs are supraventricular tachycardia. It's not VTach because there is something in between those QRS complexes. You're just not really sure what. Supraventricular refers to above the ventricles. So again, it's not a ventricular problem, it's a atrial problem. We just don't know what type of atrial problem. So that's why it just gets the name supraventricular. So the QRSs are still narrow, so it's not going to be greater than that 0.10. It can be, but generally speaking, it's less than that, 0.10 or less. And you usually have something in between there, in between those QRS complexes. But you don't know, is it a P wave? Is it a T wave? Is it a P wave and a T wave mushed together? You just can't really tell. So what we do with supraventricular tachycardia, which if you count here, this is a rate of like 220. So it's super fast. Supraventricular tachycardia just is so fast that you can't tell what it is because the complexes are so smushed together that you just don't know. So you need to slow it down to figure out what it is. So a drug that we give to slow down supraventricular tachycardia is adenosine. Adenosine or Adenocard, adenosine is the generic name, essentially is a medication-induced shock, essentially. I don't know if you want to call it that. It'll basically kind of stop the heart, and then it lets the heart kind of jumpstart itself. So what it does then, after it causes, it will cause a period of asystole, and it could be, a second, could be 6 seconds. You just really don't know. But you give it very rapidly, and usually you stack it. If you have to give it, you'll give a higher dose each time with a total of 3 doses. But you'll give that adenosine, and hopefully it restarts it and slows it down enough that you can determine what it is. Like, okay, we've got it slowed down enough, and now we can see that it's AFib, or now we can see that it's just sinus tachycardia, whatever the case may be. But it hopefully slows it down enough that you can figure out what it is and treat it. Sometimes it'll stay slow, but not usually. It's usually just kind of a temporary fix to slow it down enough to figure out what you're going to do next. And then cardioversion is another potential option for SVT as well if they're unstable or not responding to the adenosine. Vagal maneuvers, you can try and get your patient to do a vagal to try and slow it down. Usually isn't going to work, but we always start with the least invasive first. But yeah, adenosine is a really cool med. Has anybody ever seen it given before?
Yeah.
Yeah, it's one of those that it sounds weird to say. It's fun to give, just because it's really neat to see what it does. But you definitely want to warn your patient before you give it, because you're stopping their heart. You probably don't want to tell them that, but just tell them that it will make them feel really funny and not feel very good, because they can. I've had patients that have thrown up before because it just. They just feel awful when they are having that period of asystole. I'm just going to kill you for a second, but don't worry, you'll come back. So you just give that medication rapidly, tell your patient that you're getting ready to give it so you can warn them. And you also want to warn the CMC, if you're at a facility that has a central monitoring station, you want to let them know too. So that way they're not calling a code overhead when they see a patient go asystole like that. So, all right, then you have your normal sinus rhythm with PVCs. So your sinus rhythm with PVCs, it can be benign. Your PVCs are your premature ventricular complexes. I don't have PACs on here. I need to add a slide with PACs. PACs then are your premature. What? I'm sorry?
I have a question with the adenosine. Is there a time frame that
is like too long, that like if you gave too much or something like that, then, you know, is there like an anecdote to bring them back, I assume?
It is, I mean, it really is temporary, and it's not, it's a set dose. It doesn't, it's never, you're never going to give like a one dose bigger. It's always, which you guys don't need to know this, but it's always, gosh, I always forget, is it 6, 12, 12 or 6, 6, 12? No, I can't remember, but it's always 6 is the first dose. And if that doesn't work, you go up to 12 and that's it. That's the max. And it's got a really short half-life. So there's not an anecdote. I mean, if they're going asystole, then you just need to, and they don't come back, you just need to start CPR. That would be the anecdote to bring them back. So
That makes sense.
yeah.
I just wondered.
Yeah, no, that's a good question. So with your PVCs or your PACs, they can be benign. Some people have them, and it really doesn't signify anything. It can also be caused by stress, from caffeine, a lot of the same things that can just cause tachycardia as well. But it can also cause, or can be caused by electrolyte disturbances. So if they're starting to have a lot of frequent PVCs, you would definitely want to be checking an electrolyte profile to make sure their lights aren't out of whack. So these would be considered a unifocal PVC. And a PAC, the only difference, so when you look at your PVC, you know, it's a wider complex. It's a usually bigger complex, and the PACs basically look just like the normal QRS in the patient's rhythm, except it's closer and it occurs before the next beat. So it's just a premature beat is basically all a PAC is, whereas a PVC is like a whole nother complex that comes up. So these are coming from the same foci, the same irritable foci that is causing this unifocal PVC. So you can see that they both look the same. So then multifocals are coming from multiple foci, so they look different. So you can see that these two PVCs do not look the same, so they're multifocal PVCs because they're coming from different sites. Then you have Bigeminy. Bigeminy is every other beat is a PVC. So this is usually not good. This can be an indicator that they're getting ready to go into VTAC, and often caused by electrolyte disturbances. So if you notice that your patient's starting to have a lot of PVCs, they're having runs of PVCs, then it's classified as like a run of VTAC. And now they're having like Bigeminy, you definitely want to be getting, you know, on board real quick with trying to figure out what's going on, because you don't want, because as I mentioned, if they're severely hypokalemic and they code, it's going to be hard to get them out of that code until you replace that potassium. So you want to try and get that corrected before something bad happens. So with this Bigeminy though, also, sometimes your pulse oximeter monitor can be a big indicator that something's going on if they're not on a monitor. So if you're on an unmonitored floor, or, you know, even in the nursing home or wherever where a patient isn't monitored, and you're checking a pulse ox and you're getting crazy readings, that's usually a red flag that should go up, like, maybe we should be checking an EKG or something. Because sometimes the pulse ox may not pick up those beats on the oximeter. So it might say that their heart rate is like 40, when really, but you'd like check a pulse or something else and it's saying that their heart rate is 80. So, because, you know, it's every other beat, so half the beats sometimes may not be pulsatile. So that could be an indicator that they might be in Bigeminy if they're not on a monitor. And also the pulse ox sometimes will find a fib, because you're checking their pulse ox, and it's like all over the place. Like 1 second it's saying 80 and the next second it's saying 120, and it's just like not being consistent. I know that, you know, usually we recheck with a different machine or something, but if you've got two machines that are doing the same thing, you should be getting an EKG for your patient to see what's going on, because those things can really cue you in that something might be wrong. So then, as I mentioned, if you start having rows of PVCs, then it's classified as VTAC. So this would be considered sinus rhythm with 3 beats of VTAC. So once you go 3 beats or more, it's considered a run of VTach. They could have 8 beats, but it's still VTach. It's no longer PVCs, it's a run of VTach. Then here we have our VTach, our ventricular tachycardia. It's a ventricular problem. So you're going to see the problem with the QRS. Here's your QRS and nothing else. It overrides whatever else would have been going on in the atria because the ventricles, take over. So it's just going to be that sawtooth-like line and nothing else. Wide QRS. So here you can see the difference between VTach and SVT. So you see SVT's got those little, it's got a P wave or a T wave or something in it, and it's more narrow. Now we have our VTach. Those are not there anymore, and it's very wide. So this is our ventricular tachycardia. VTach can have a pulse. It is lethal, though, if it is not corrected as soon as possible. So VTach, the patient could be stable for a moment. I'd say the longest I've seen someone stay stable in VTach is like 30 minutes, and that's impressive. Usually they're not going to stay stable that long in VTach. Oh, little kitty. Sorry, I'm distracted by your cat there, Tara. You're fine. So with VTach, if you see this on the monitor, again, we're always going to check our patient first, make sure it is true VTach, and checking your vital signs. So you could walk in and they could be perfectly fine, but you want to make sure that they're stable, that they're okay at the moment, and you're staying with them because they definitely could lose a pulse at any minute. So if they have a pulse, and they're stable, you might be able to correct it with medication, get amiodarone on board right away, potentially lidocaine. Lidocaine we don't see quite as much anymore. Amiodarone is really our big anti-dysrhythmic that we're going to give. And could be a result of electrolyte disturbances. Again, hopefully you're catching it earlier than this, but you're going to be checking all those things. Now, if they become unstable but still have a pulse, so they start having chest pain, they're hypotensive, they start having a decreased LOC, you're going to want to try and cardiovert them right away. So basically, cardioversion is always going to be used with a pulse. Okay, you're going to cardiovert if they're unstable with a pulse. Defibrillating then is if they have no pulse. Defibrillation is in a code situation and they have no pulse. So if in the midst of getting ready to cardiovert someone who's in VTach and they lose a pulse, you're going to switch right over to defibrillation and just shock them. And you're going to start CPR and the whole 9 yards. So when VTach becomes pulseless, you treat it like VFib, which is our ventricular fibrillation. Just like in atrial fibrillation, the ventricles now are fibrillating or just quivering. Well, as you can imagine, if a ventricle is just quivering and not pumping, you're not going to have a pulse. So VFib is always pulseless. VTach could have a pulse, but VFib is always pulseless. They just have that multiple foci that are firing in a disorganized manner, and the ventricles are not able to contract. So you're going to do CPR and defibrillate as fast as possible. Anytime a patient doesn't have a pulse, you're going to start with CPR. We know that. But defib is always like the very, very close second. Like you want to defibrillate a patient as soon as possible, just like starting CPR as soon as possible. And then epinephrine is going to be our first drug of choice for any pulseless rhythm. Anytime a patient no longer has a pulse, epi is going to be the first drug of choice. But again, our anti-dysrhythmics are a potential option as well with our amiodarone and lidocaine after that, but epi is always going to be our first choice for pulseless. So here is what our defibrillator looks like in most facilities. You might have little older versions or newer depending on where you're at. But here is, let me zoom in here. Here's our sync button. So that is the button that we push if you are going to cardiovert. So if you're going to cardiovert your patient, if they have a pulse, if they're in AFib or SVT or VTach, you know, whatever one it is, but they have a pulse, you will cardiovert. So you're going to make sure that sync button is turned on. When you turn on that sync button, it'll put an arrow above every QRS complex. Then you're going to charge it. And then after it's charged, this button right here is your shock button. And then you'll push your shock button, which what do we always do whenever we're right before we shock a patient? What do we always need to make sure?
Nobody's touching the patient.
Yeah, everybody's clear. Not touching the bed either, because the impulses can go through. So making sure everybody's clear, and then you shock them. So then it will shock them on the QRS complex that needs to be shocked. If they go into a pulseless rhythm, then you have to make sure you turn that sync button off, because then it's going to wait. Especially if you're going if they go into like VFib, where there's nothing that the machine could like find as far as the QRS complex, it's not going to shock them. So you have to turn off that sync button if you need to defibrillate. So sync on if you're cardioverting, sync off if you are defibrillating, but it's still the same machine. And usually our defib, we're going to go up to at least 200 joules for our biphasic machines. I don't think there's too many monophasic machines out there anymore, because then you have to go up to like 360. So the energy travels differently, so you got to use more energy. All right, go back there. All right, so now we have asystole. Asystole is the absence of a rhythm. There's no rhythm, there's no electrical activity. So since there's no electrical activity, we don't shock. Regardless of what the TV shows show, we do not shock asystole. It will do absolutely no good. What shocking does is resets the electrical activity to try and get it back into a normal rhythm. With asystole, there's no electrical activity to be reset. There's nothing. So we're not going to shock. What we are going to do is CPR. CPR, CPR. That's about the extent of what we can do. And epi. So your epi is still going to be your drug of choice for your any pulseless rhythm, including asystole. So with asystole, though, you really need to try and potentially rule out other problems that might be able to be corrected to help bring them back. So those things that we consider are our H's and our T's. So our H's are hypovolemia, hypoxia, hypothermia, hyper or hypokalemia, and hydrogen ion, which is our acidosis. So those are our H's. And then our T's that we want to consider are our toxins, because it could be a result of, drug overdose or something like that. Tamponade, cardiac tamponade, tension pneumo, and thrombosis or clots. So those all could potentially be a reason for a patient going into asystole. So you always want to think of those things that you might be able to correct to help bring them back. And then we have PEA. I don't have a picture for PEA because PEA is sinus rhythm without a pulse. So PEA is pulseless electrical activity. So as it implies, pulseless, but there's electrical activity, but it's sinus rhythm. So the other rhythms, like VFib and VTach, they can be pulseless and they do have electrical activity, but they have a name because they know what it is. It's VTach or it's VFib. PEA is sinus rhythm without a pulse. So I know it seems weird that that could occur, but one big thing that PEA occurs in is cardiac tamponade. So with cardiac tamponade, either after surgery or, if they've had open heart surgery and they've got blood filling in the pericardial sac, or with pericardial effusions where they just have fluid, or, whatever the case may be, what's happening is that pericardial sac is filling with fluid and it's starting to compress the heart. There's no problem with the electrical conduction of the heart, but now the heart can't beat because it's being squeezed. So the electrical activity is still going through the heart, but it's not beating anymore. So that it's like a band is just starting to kind of go around the heart. So you'll see a normal sinus rhythm still, but your patient's coding. They have no pulse and you're going to treat it just like asystole. So PEA, you're going to start CPR. You're not going to shock because they have a good rhythm. The rhythm is not the problem. It's the heart itself. You know, sometimes I have to crack open a chest and relieve the pressure and drain the pericardial sac. But then the other H's and T's could potentially cause PEA as well. But PEA, again, you're still just going to treat it just like asystole with CPR, and epi is going to be your main treatment for that. All right, now our blocks. Last but not least, where are we at? We still got 10 minutes. Okay, so we have our blocks. Your first degree block is the main one that you need to recognize, which is very simple. It's really, all it is your PR interval that's greater than 0.20. So when you're measuring out your PR interval, you'll mark it up next to a box, and if it's greater than one of those big boxes, then you know that your patient is in a first degree AV block. Generally, your AV blocks are benign, sometimes a result of just being on beta blockers, or if they've had an MI in the past, they might have some slowed conduction in that pathway if that part of the heart has been damaged. But generally, it can just be benign, and it's something that you just need to monitor because it could potentially lead to a worsening block, such as second or third degree. Your second degree blocks could be a result of medications as well. So there's a problem with the conduction from the SA node to the AV node. And generally, when you're looking at your second degree block, you will see that you have a P wave. You might have a PR interval that's getting longer with each beat, and then it drops a QRS. So you'll see like a P wave, and then there won't be a QRS following it. There's two different types of second degree block. There's type 1 and type 2. We're not going to go into detail about those. So don't, like, in your reading and stuff, don't get involved in those. Just know that, you know, your first degree block is your PR interval that's increased, or that is greater than 0.20. Your second degree block, you might have some, you know, a P waves in your PR interval that's getting longer and longer, and then it drops a beat. And then your third degree block, or your complete heart block, is where there's just a block in from your SA AV node to your bundle of His. Like, they're not communicating whatsoever. So